So when we look at the Stomatognathic system, obviously this is the facial skeleton, the mouth, lips, tongues, and the surrounding tissues, the maxilla and the mandibles, and it's how this zone works with both the cranium, the throat, the neck, and has influence on and is influenced by a whole variety of things. So if you thought that we were going to do just a little bit of a quick series of lectures about the TMJ, then you're going to be mistaken, because there's an awful lot more to talk about than that. So I've just got a little bit of obviously an entertaining picture here for a moment, and I can't remember where I got it from now, so I can't credit it, sorry about that. But obviously muscles, joints, fascia, autonomic tone, circulatory factors and so on, airflow and digestive functions all come together. And when we consider the muscles, as we're going to go through some of them, we can just be aware that the tongue is a huge muscle as far as the Stomatognathic system is concerned. So at the beginning of someone's treatment, they may not be able to use their tongue very well, but hopefully by the end, and by the end of this series, maybe you will also have an extra respect for how the tongue works within the body, how it sets up all sorts of problems, and how if you work and include within your work issues to do with the tongue, then you'll be able to liberate all sorts of different things around the Stomatognathic system. But so anyway, what are we going to cover? So in session 1, we're going to just start out with a general overview. So we're going to obviously explain that the Stomatognathic system's functions include mastication, deglutition or swallowing, phonation, respiration, but it's also involved in a whole variety of other behavioural characteristics and activities. So it's going to be involved obviously in communication, but with the face, both non-verbal communication and interpersonal social engagement type communication, and so on. So there's lots of different sorts of functions that are going to come into play. And we set the scene by saying that the TMJ itself is involved in a whole proprioceptive dynamic, so that the Stomatognathic system linking from that TMJ is going to be involved in global body balance. And understanding how all of the general proprioceptive signalings and postural control of centre of gravity and shifts both in the static posture and in the dynamic walking posture, for example, if we understand how all of those linkages come together, then we can get some insight as to neurologically and fascially all of the structures of the body are then going to feed into ultimately the alignment of the head, so that that influences then the hanging of the jaw underneath, lets the hyoid act as a gyroscope and just stabilizes this zone for the most efficient function. So we certainly see that posture is a really great driver for the Stomatognathic system alignment, and there are definitely lots of issues with respect to changes of posture over age and how your muscular function is going to adapt over age. But essentially, as you're thinking of posture, what you also need to be able to do is to say, okay, well, if the posture is adapted, is it leading to any as yet unreported dynamics of the Stomatognathic system? So in fact, when you're watching someone and asking about case history factors, you can ask about how they're talking, looking at the mouth, how they're responding, how they are using the mouth. So you can obviously get them to swallow or chew, and then you can see how they're doing those actions. And you actually, what you need to do is, even if you're focusing on, for example, pain in the back of the neck, you know, with someone at the office, or you know, anything like that, even these sorts of simple, seemingly musculoskeletal biomechanical problems, it's going to be worth your while actually looking at the functionality of the Stomatognathic system, even if they're not complaining of issues, because as we'll see in the whole course, these two are very much related. But overall, the Stomatognathic system is one which, although it primarily involves sort of oral and nasal structures, it involves all sorts of things to do with special senses. And you can't have balance posturally without engaging your visual system or your vestibular system. So you absolutely have to have these special senses being able to have the efficient function. And so your body and face and throat will orient to keep those in the right dynamic. But we're also going to think very much about airflow, aeration, humidification, immunity, all of these sorts of things as well, and then taste and early digestion, but also turning for hearing, turning for vision, but focusing on communication. And there are lots of different things which will then lead to the way that we have to reposition, reposture our head in order to make sure that we're receiving the best signals and having sensory integration, which we're trying to adjust and accommodate. And as we do that, we realize that actually a lot of the muscles that are involved are the muscles of facial expression also. So yes, we use the lips for speech and eating, and the tongue similarly, but the facial muscles are really curious sets of structures. And obviously, when we look at someone, the first thing that we see is their facial expression, and we take a view on that, and we actually think, what does that expression mean? And usually there's all sorts of facial mimicry which starts very early on. If someone comes to you smiling, then you tend to subconsciously smile yourself. If they come to you frowning, you, what's going on here? And your face has reacted before you've quite realized what you've registered. And so there's this mutual, if you like, interpretation of each other's emotional states that you can read into, which automatically starts to activate various things. And just as a curiosity, the actual facial muscles themselves, you may or may not know, don't have that many of their own proprioceptors. So they don't have intrinsic muscle sensory receptors embedded within themselves, and they actually use the trigeminal system in order to provide feedback. So there's a piggybacking through the trigeminal system, so that you have this communication between 7 and 5, which enables the brain to know how you've registered and what you're doing with your face. And actually, if you have, for example, Botox, I mean, Darwin would have loved Botox, and I'll explain why. When you have Botox and you remove the ability of the face to have an expression, great, you look less wrinkled, and so you may well feel emotionally happy if you were riddled in advance, and now you've got this nicer, smoother, younger looking skin. But there's been some curious thoughts around this because of the way that if you make a face expression, the action of making that expression feeds back through the trigeminal system and then links onto other emotional centers of the brain. And it actually goes to various regions such as the precentral gyrus and all sorts of things, and the hippocampus and the posterior cingulate cortex, all of these things which become active when we have emotional experiences and are involved in helping us retrieve our emotional memories. When the face puts itself or is put into the expression of, say, happiness or sadness or whatever, then that literally links into these emotional centers of the brain so that we can make ourselves happy by having a happy face. We can obviously make ourselves angry by having a angry face. But curiously, if you are unable to make an angry face, the more you are unable to respond aggressively, actually you become happier, because essentially the amount of angry engagement of these higher centers becomes diffused, and the mere fact that you're now prevented from engaging your angry means that you are essentially happier. And so again, people have done a bit more sophisticated research than I'm describing, but there is this curious relationship that having Botox actually may well seem to make you happier through these other links, other than by simply removing your wrinkles. So it's a really sort of curious little thing. So actually your facial muscles, I think, are anyway a forgotten area in osteopathy. They're something that we perhaps don't pay enough attention to, and you sort of wonder why, because there's some really interesting functions of the mouth, the lips, their face, the ability to make a seal, how they work in speech, but how they relate to airflow. And so the face is really interesting, and so it's something that we want to be able to do a little bit more work on. And then again, just lots of massages, lots of rehabilitations, and sometimes the people with chronic TMJ pain, and they get this frozen face and they can't move, and so your face literally forgets how to be different. So there's all sorts of rehabilitation which literally require someone to help put their face back into happy in order to bring their brain back into the memory of how they should then orchestrate on the efferent side the motor movements for facial expressions. And if you do that, if you bring facial expression back in your chronic pain patient, then you're going to improve this social communication. Because one of the things that's really intriguing about the Stomatognathic system is the way that it allows us to really interact as social beings. And so, yes, there can be lots of non-verbal communication around the rest of the body and so on. But it's absolutely this sort of facial dynamic and the eyes and the widening and all sorts of things involving the facial muscles. And Darwin obviously had quite a lot to think about with respect to the development of the facial muscles in terms of evolution, and tracking the complexity of facial muscle anatomy and complexity of usage coming through various different animal groups and on up through to primates, showing that it was increasingly related to the ability to socially engage, the variability and complexity of the facial musculature. So he had a lot to say about that in terms of evolution and species development. And then we finally get to something like the social engagement system, which is obviously the sort of fuller discourse about the polyvagal theory. And it obviously links us into this being autonomically, physiologically, and homeostatically prepared for whatever we're exposed to in our environment. So if our environment is safe and nurturing, then our sort of physiology is going to be one certain type, and we're going to get on with some sort of homeostatic level. If we perceive a threat, then up goes our sympathetics, up goes our bodily adjustment, altering our heart and respiratory rhythm, so that we can then obviously, act and react. And what's supposed to happen after that? Obviously, once the threat's gone, we perceive the threat's gone, that's supposed to downgrade, etc. and so on. If we have too much threat, then obviously we can go to a freeze reaction, fear paralysis, play dead sort of mode, and we can become unresponsive as opposed to hypervigilant in our responsiveness. And all of these sorts of things we get locked into this confused relationship whereby our autonomics don't release us from this fear, fight, or play dead dynamic. And so we never actually get to use the third part, so rather than this sort of awkward playing between sympathetic and parasympathetic, we never quite get to use our social component, our third set of nervous structures, the hierarchy which came later in terms of evolution, about how we can display empathy, how we can have communication, how we can use language, and etc. So there's all sorts of interesting things that we need to build in with respect to the social engagement system, which actually uses all sorts of cranial nerves, and you could almost argue that you grew your cranial nerves in order to communicate. It uses that many of them, and that your vagus nerve is an orchestrator and a narrator between all of these different stories, all of these cranial nerves are trying to play. So it's literally helping people to become discoursive, interactive, better self-respecting, balanced, settled, and ready on an easy, responsive, reactive platform of physiology that's settled into something which gives that person agency, and they have the volition and the sort of success when they carry things through. Anyway, so we talk a lot about all that sort of stuff throughout the course. We also talk about head nodding and upper cervical spine mechanics, and how we need gaze tracking, and all sorts of things about sort of vocalizations. And we really talk a lot about, actually, it's many of the issues with how people might present with, say, neck pain or jaw pain or something else, or sort of head pain when everything gets, a bit awkward, is often to do with the way that we're trying to communicate, or we're over focusing, or we're holding back, and we're not sort of free, etc. So when we do our case histories, we're not just asking about biomechanics of the jaw. Does the tongue stick out? What's actually happening in the movements of the neck. We're actually being much more creative than that, or we should be, in order to understand what's happening in that person's world and context, and what historically will have left them in with a legacy of stuff such that they now can't respond appropriately to the ongoing situations that they're in. So all that sort of stuff's fascinating. And of course, this relates absolutely through from birth all the way through. And we do talk quite a bit about the pediatric arena as well. And we look at that bonding, that facial recognition, the security and stability of the physiological responsiveness of the infant, and the arousal states and so on that goes between mother and child, and how that then settles them so that they can then go on and sort of develop. So the sort of maturation of all of your reflexes based on visual cues, and the way that simply having the right facial expression in front of the baby can settle the baby and infant stress, strain, hormonal regulation, rhythmicity, temperature control, and so on. And so we obviously need to look, when we're dealing in the pediatric stomatognathic system, about how mum is doing and mum's mental health and all of that. So there's all sorts of little things that we can touch on through when we're looking at the assessment of the infant and how the head, neck, throat, etc. functions, and how the dynamics of the tongue and the facial skeleton, etc., is trying to organize itself, and how the physiology of the baby is settling. We relate that through to the maternal dynamics. So we set the scene for all sorts of things in session 1. In the session 2, we do all sorts of things with the upper cervical spine, and we remind ourselves of the anatomy and the shapes of the facets, and how actually we've probably forgotten them, the absolute sort of oddities of all of the cervical spine facets. And we talk to you about refining your joint positioning. We talk about the lengthening of the neck and the easement. But we also talk about the link from the chest through to the neck and how that relates to itself, and how the dynamics of the musculature, both on the front of the neck as well as the back of the neck, leads us to need to come ventrally, such that actually what we're trying to do is to look at how the cervical column can be balanced in a dynamic, integrative way by assessing it from the front. We get so, we're so used to doing things from the back, and actually usually what we do when we dip in on the back is we lift the patient's neck up and create a bit of extension, but actually probably physiologically most of us need to drive the neck posteriorly. I don't need to bring this in military stance because that includes airway and all sorts of things, but actually what we need to be doing is able to posterize the neck and assess all sorts of things ventrally. So we need a new insight into how we think of cervical bony segmented stacking with the cylinder of the ligamentous arrangement, but also the cylinder of the dura within, because obviously we can use the impetus, so the need for air and throat and swallow to be aligned. If we can keep that appropriate, then we need to have the neck settled. And actually the dural dynamic is going to be at its most eased when you have the appropriate air space, swallow space, and so on. But driving actually the cervical column means that we get this funnel-like handle up through the cervical spine, up through onto the dura as it opens into that, through that foramen magnum, into the infratentorial space, into the tentorium, and you can drive it from the neck. We do all sorts of interesting things through to the cervical column, and in fact it's probably much easier to influence this infratentorial world from below up than it is from above down. So we talk a lot about that because there's all sorts of things within the stomatognathic system, relationships with the cranium and the cervical dynamics that we need to consider, including this conceptual framework and dynamics of the muscle or myodural bridge, which is at the upper cervical spine, and how that actually tweaks away and gives us all sorts of perspectives on how we might be looking at the fluid mechanics and dynamics inside the cranium with CSF and venous flow, etc. So we get into all of that sort of stuff in session 2. Session 3, now we're into airways. As I said, probably one of the biggest factor for having head and neck alignment is you're probably going to say eyes and ears as in vestibular, and I'm going to say airflow, because actually getting the air in is critical for the metabolic needs of the body and for all of our homeostatic mechanisms. And so if you don't breathe properly, and you have to breathe through the nose, have the space within the face correct, and the space down the back of the pharyngeal zone in the back of the throat, that's all critical as to how the air is then dynamized throughout the rest of the respiratory tract. And so the efficiency of your physiology depends on this usage and priming of your stomatognathic system, and you breathe differently into your diaphragm or lungs depending on whether you've moved your air through your nose or your mouth. And so we look at all sorts of intriguing little articles about flow and where it gets through into your nose, and does it get into all the nasal sections and your turbinates, and does it how does it then flow down your nasopharynx, and what actually happens with all the particles of air that you breathe in. And in fact, if you don't breathe in properly through your nose, actually you don't breathe your sinuses into being, because you actually do need nasal airflow to literally pump out, inflate out and puff up your sinuses developmentally throughout your first several years of life and through into your childhood and early adolescence. And some people are still growing their maxillary sinuses post 20 years of age, for example. So there's all sorts of interesting things there, and about how airflow, as it whistles up your nose, goes up your eustachian tube, does interesting things in your middle ear and out into your mastoid cells, for example. But we also talk about how the soft tissue dynamics through from the mentum of the chin through onto junior hyoid, onto the hyoid bone, onto the root of the tongue, from the tongue onto the soft palate up onto the pterygoid plates of your sphenoid, and you get this dynamic muscular bridge of airway dilators which stabilize. So you get this link from the chin to stabilize your hyoid, so that then the palatoglossal muscles from the hyoid and root of tongue sort of traction your soft palate down, but they can act against some other muscles which traction your soft palate up through to the cranial base, such as the tensor tympanis, and they can all couple with your palatopharyngeus, which comes down again from the soft palate and pulls down in a different way. And as we well know, maintaining appropriate airflow either side of the soft palate is critical for your sleep dynamics. So we do touch on sleep, we touch on arousal, we touch on this with respect to infants, but also apnea, so sleep apnea dynamics later. And it really helps us to understand, when all of the stomatognathic system is out of kilter, why people have sleep disorders, why they have headaches, why they have all sorts of difficulties with depression and sort of paroxysms when you start to get your sleep cycling broken down. Because sleep is a critical thing, and it alters all sorts of blood chemistry issues and autonomic tones. And I think it really does help to illustrate the absolute sort of suffering that TMJ type patients get, beyond the mere fact that they've got a pain in the jaw, or that the dentition and occlusion is not quite right. And what we begin to see is, as we're doing this, that as the sleep alters and the airflow is or isn't stabilized, that the autonomics link in with that, but then the autonomics themselves alter your global motor tone, and it alters, as I say, your blood chemistry. And once you start to then have compensatory bruxisms, tensions and tightnesses through here, it begins to mean that the whole of your stomatognathic system does not now pump the head or mobilize the dynamics for the venous drainage of the head, and starts to have all sorts of other effects which lead to all sorts of complications, such as how does the cranium and how does the brain tissue drain, and how is the jugular foramen operating, and what's happening when the jugular foramen is not free. And everyone's going to say, oh, well, it irritates your vagus. Well, yes, I suppose, but the jugular foramen is probably more influential with respect to the jugular vein, and it's if you have tension and tightness on the jugular vein from the jugular foramen, then that has more significant physiological effects than the supposed little bit of pinching of the vagus nerve at this point. And everybody says jugular foramen, vagus, but I think that you should be jugular foramen, jugular venous drainage, and then all the other little nerves that go with it, such as the glossopharyngeal, as well as the vagus. So we do talk quite a bit about the circulation intracranially. We talk about the venous sinuses, we talk about dura, and I give my own version of the reciprocal tension membrane dynamics, because I don't utilize the involuntary mechanism in my own practice. I do my own version of a bit of a push-pull, so I have a voluntary cranial dynamic as opposed to an involuntary cranial dynamic. But nonetheless, you can mobilize using the skeletal framework of the skull, using sutural dynamics, using stretch of tentorium to hypothesize that you're getting into all of these spaces. And of course, if you can free off the drainage, then you can free off the drawing out through the cranial venous system and the cranial lymphatic system, the cerebrospinal fluid. Sorry, a little bit of barking in the background there. But yes, so if that venous and lymphatic flow is not appropriate, then of course it's going to impede on the cerebrospinal fluid flow and therefore the brain health and so on. So the issues with respect to astrocytes or the Virchow-Robin space, we go through that, and we go through also the accessory channels down through the vertebral venous plexus, but also the pterygoid plexus. And we also then bring in this whole dynamic of the venous flow and the cerebrospinal fluid, especially in the infratentorial space with respect to the cerebellum by this issue of the myodural bridge. So lots of things in session 3. Session 4, we tend to then look at eyes and balance and head orientation and so on, vestibular integration. We also start talking about primitive reflexes and retained reflexes with children and so on. You know, this isn't a lecture which is designed to go through that in its entirety, but it just hints at how these things are going to be in relation to itself, to this topic. Also, I don't give an enormous full discourse onto dissonance and vestibular dynamics, because again, that's a huge topic, but we do begin to illustrate how these things can come into being, and we also come back to that in our later sessions. But for now, what we look at is how posture and equilibrium are organized. We go through ocular, spinal, vestibular relationships. So we look at how the body information goes through with the cerebellum, goes through to various vestibular nuclei, etc., and leads to ocular adaptation and so on. And we look very much at how the neck is linked into all of these types of dynamics. But we also recognize that you need to hierarchically develop your nervous system, and we do begin to, as I say, look at these from a primitive reflex integration point of view, and we point out that things like suckling is a vestibular friend. So given the way that the babies may or may not be able to sort of suckle and develop, may well already be priming asymmetrically their vestibular dynamics. And we look at how you can organize with stuff with respect to eyes. We look at eye muscle attachments, and we look at sort of seeing if we can, you know, dynamize anything there. And we also just, you know, chat briefly about how we might be able to sort of look at things like drainage in the eye. But again, this isn't going to be, you know, a full treatise on ocular disorders and osteopathy, because again, that would be another enormous topic. But it just sets the scene for how these things may well be relevant for your alignment of your stomatognathic system and your cervical spine and so on. We then look at the issues of growth, because as we know, the facial skeleton and as well as the cranium, yes, but the inferior cranial fossa and the facial skeleton really grow. And so this osseous stretch, this periosteal sensitization, this imprinting across with the teeth and dentition and so on, is a fascinating story that we need to understand more. Now, I'm quite keen on periosteum, I'm quite keen on osseous dynamics and getting into the bone, because of the sensory information that is derived from this osseous component, periodontal ligaments, the bite, etc., through onto the trigeminal system. And then, though, how the trigeminal impacts onto vagus, and what the trigeminal nuclei then also attach to or relate to and link to, because then when you get pain and irritability, whether it's a baby, a middle-aged person, older person, somebody who's had dental trauma, all of these things mean that the sensorial environment of your stomatognathic system is critically important to consider. And this is really, I think, where osseous dynamics can come into play, so that we can begin to look at moulding issues throughout this whole zone. So yes, facial skeletal growth needs to be talked about, the changing alignment and the anatomy of not only the outside brain case space, for example, and plagiocephalus or torticollises, but the actual alignment of the air spaces, the dural spaces, and the swallow throat esophageal spaces. So we talk a little bit about bones, and we talk about osteoclasts, and we talk about bone receptors and talking to the bone and unwinding intraosseously from a non-involuntary mechanism point of view. So how you do a sort of like an ordinary push-pull, soft, gentle version of intraosseous dynamizing to help improve the sensory environment. So yes, we hint at that that and hint on these vagal trigeminal links and how this is going to have relevance for a whole variety of head and neck type symptoms, and how all sorts of things converge and lead to a variety of irritabilities within the whole nervous system. And we look at increasing allostatic load, and we look at the burden of this irritability, inflammation, and diffusion through our rest of our central nervous system. Sorry, I've got two tiny little sort of rugrat things, and they're just growling at each other because they're just having a moment. So anyway, we're looking at how the vagal and trigeminal dynamics build in together. So when you have pain in this area, dysfunction in this area, how that links in, how it relates to the autonomic tone, maybe migraines, how it then links out into vestibular dynamics, but also how it links out into the emotional dynamics, and just builds in pain experiences, pain behavior patterns, and this burden of perhaps ongoing neural networking that can happen if you have trigeminally oriented or any pain oriented for either for too long or from too early an age. In session 6, we look at a whole variety of things now that we can start to consider, whereby we come back again right from the beginning at the developmental dynamics, the social engagement dynamics, and really understand a lot more about the dynamics. So yes, we go through the Morrow type of reflexes. We realise that it's autonomic stability, but we also then realise what happens when you have problems with people not letting go because they're locked in either a withdrawal reflex or some form of social engagement or Morrow type of problem. So we can talk about how we need to have a sort of a pact within our bodies and our engagement system so that we can help identify those people whom are locked in, and so rather than palpating just the facets and just looking at the mechanics of the face, we can begin to try to understand where they're at with respect to these higher order dynamics, because it's certainly true that the way that your autonomics build up leads you to have motor patternings which are then going to fix your stomatognathic system. So any amount of unwinding isn't going to release those until you've understood in what ways they've been sort of trapped. So yes, we talk about the primitive reflexes a little bit more and how it might link into this, but we also then talk about the birth strain, what you'd normally use your primitive reflexes for, to get you really down the birth canal and get you onto your first feed and all of that sort of stuff. And we give you some idea about how that birth strain stress might then have relationships with a whole variety of these things, and how birth strain might distort those, as well as distorting the generic stomatognathic system. And we give a few actual different insights about these torticollis and a few different perspectives. So again, we look at these birth strains, and again, we've got some pictures which I got from somewhere else ages and years ago, and I can't, they are now. So again, I can't credit them, but we talk about how these influences mean that many birth strains are better assessed from here than they are from here, and that as far as the infant is concerned, sensory information from here is far more important than the sensory information from here, and we go through all of those sorts of issues. So there's quite a bit that we then cover with respect to the primitive reflexes, in terms of an overview, how we need the writing reflexes, and we talk ultimately, we set this up understanding ultimately how movement coordination goes together, and we're going to look more in later sessions about motor sensory integration, learning behavior and development, and so on. And so we can begin to see how the stomatognathic system gets caught up into all sorts of things, but we always keep coming back to this idea of this: your muscles only do what sensorially the information on the afferent side is telling one to do, or how the processing with respect to that afferent information, how that processing is then coordinating the motor efferent output. And so we can see that actually the end dynamic that you end up being able to palpate is really interesting. And we just remind people about the fact that all sorts of things in infants are actually to do with eyes, and eyes will override all sorts of things, because if they can't see properly, and they can't balance properly with respect to vision, then the neck is absolutely held in all sorts of things, and there's probably a whole dynamism of torticollis with respect to the infant trying to work out what's happening with respect to their, you know, sort of mum's face and so on. And we also talk about somites and arches a little bit and just hint about whether torticollis is in fact a pharyngeal arch disorder, and so on. And then we come to swallowing and oral motor dynamics. And so, yes, we do swallowing for adults, but we also do swallowing for infants. So there is definitely some issues of suckling, tongue tie, what should be happening with latch, you know, all of these sorts of things. And so, yes, the dysphasias and, you know, the need for head orientation and posturing, but also these, absolutely these issues with respect to pediatric swallow, the suckling issues, what you need to look for, how everything has to be coordinated, the influence of the tongue and the influence of the bottle and how the mouth is used and all the rest of it. And we do definitely try to debunk a few myths. And so one of my favourite myths to debunk is this issue about the fact that the suckling actually is pushing up via the tongue onto the soft palate, and onto the hard palate, and from then onto the vomer, and then through the ethmoid, and it mobilises the whole of the cranium and sphenoid back from this pressure of the tongue in the suckling up onto the roof of the mouth. And look, it just doesn't happen. It just doesn't happen because now, wait a moment, I'm not saying that the whole of the suckling issue doesn't completely mobilise the cranium, which of course it does, but it does it through a route which is not up the palate and through the vomer. What it actually does is through the vacuuming and the use of the muscles on the underneath of the throat, it actually pulls the cranial base down. But we go into that in a lot more detail, so you'll understand what I'm saying if you're not quite convinced at this particular moment in time. Then session 9, we go through actually the speech and auditory dynamics. So we actually start setting this up about ear function, and we talk about speech, but we do it with respect to actually, you want language. Okay, you want to be able to speak, but you want to have language. How does that work? How do you get to have language? And so we talk about this balance of receptive and expressive, and the sensory processing, but we talk about the fact that actually there's an awful lot of motor coordination that has to go with this. You've got to learn to walk. So you've got to learn to roll, sit, crawl, step, run, before you could talk. And so all of these things, we go through that in quite a bit of detail, this developmental pathway, because it's just utterly important for you to realise that if you want speech that is smooth and articulate and Shakespearean and lyrical and lucid and all of these things, then you have to have your dynamics of your speech production. You have to have those really complex movements, really smoothly orchestrated from your motor planning point of view. And the decisions as to what to say. Have you heard? Have you been able to reflect? Have you understood? Can you plan your response quickly? And can you get all the words out in the right order? Or are they all going to get jumbled up and you're before you've managed to say them, or your brain's going too fast for your mouth? And all of these things actually relate back to the cerebellum. And so we do talk quite a lot about how the need for repatterning your cerebellum on the motor coordination side of things sets you up for your language, memory, and emotional dynamics. So we spend ages on that because it's fascinating. Then obviously we finally come in session 10 down onto laryngeal mechanics. So we explain about the vocal cords, we explain about the cricothyroid visoring, and we look at hyoid and tongue placements, and we do all sorts of things about, you know, using platysmus and doing accessory things there. And we talk about laryngeal replacements and how to avoid overpressuring the vulnerable structures of the throat, and how to actually find the thyroid notch and where is your hyoid anyway. And so we go through all sorts of palpations to do with that. And then we talk about the inner workings of the vocal cords, and for you to understand how both from the very inside and then both from the very outside, how all of these layerings in this region ultimately mean that the visceral space for your voice is balanced, especially with respect to the neck and the throat and so on, and that we look at all those subtleties and give you some ideas. And then in session 11, we actually then finally come to the TMJ and start talking about discs and jaw movements, and we say, well, actually, if you test the jaw this way, it's probably gives more meaning than testing it that way. And we go through a few things, and we talk about the discs, and we talk about muscles that pull on the discs, and we have all sorts of correlations that we can think about, and we understand the two disc spaces, and you know, where the condylar parts are trying to meet, and what the lateral pterygoid does or doesn't do, and how you can actually manage these, you know, sort of intraoral techniques, which is, you know, many people find them really hard and awkward or too painful, and patients don't necessarily like them, and some people seem to have a knack of doing them, but many people struggle as practitioners. So we give you some suggestions around that. And finally, we put this entire thing in the context of your cervical-brachial, thoracic inlet, mediastinal and upper limb dynamics, such that when you want this axial appendicular dynamic and your center of gravity all to come together, it then means that ultimately, because of all of that, you end up with your stomatognathic system in balance. And so we give you ways of treating from below up, which help to integrate all of these things, such as a little bit of a run through of some of the anatomy of the fascia crossing this cervicobrachial region. We talk about the alar fascia and the prevertebral fascia, and things like your omohyoid highway, and how you use the upper limb to get you in and over into the deep mediastinum or up the side of the neck, and how you begin to balance all sorts of things, such that finally, when you have someone presenting with your swallowing problems, your suckling problems, speech problems, how the breathing, sinuses, TMJ pain, headaches, some neuralgias, all these sorts of things, how actually you've got an approach which involves, you know, the throat, the cervical fascia, the thoracic inlet, the chest, the cranium, the drainage, the lymphatics, the facial sutures, you know, the orbits, the eye muscles, the vestibular, temporals, etc., and just how you put it all together, ultimately with your tongue and your lips and your face and your expressions, such that the person can walk out with a better sense of self, a better ability to communicate, and to have other people look at you and think, oh, you look better. So that's my take on the Stomatognathic system. So we've got it's at least a 30-hour program. You've got lots of, you know, 1 to 2 hour videos to watch all the way through. You've got endless PowerPoint slides in amongst that. You've got lots of handouts. You've got lots of articles and evidence, and then hints of this and hints of that, and there's lots more resources. So it's packed full of stuff, and I'm hoping that you're going to really enjoy the series. And on the course page there'll be a second little video, again just showing you some of the issues about how, you know, for logging in and all the rest of it. And so I'm just hoping that you'll really enjoy how to get a new perspective or two on the Stomatognathic system.